From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Thank you for joining this JAMA Network podcast. My name is Anne-Marie Navar. I'm a deputy editor for Equity, Diversity, and Inclusion at JAMA Cardiology, and I am delighted today to be joined by Dr. Alex Fanaroff. Dr. Fanaroff is from the Perelman School of Medicine at the University of Pennsylvania. He's a cardiologist, and he's the lead author of a manuscript just published in JAMA Cardiology titled Encouraging Pharmacist Referrals for Evidence-Based Statin Initiation, 2 Pragmatic Cluster Randomized Clinical Trials. Alex, thanks so much for joining us.
Thanks so much for having me.
So let's jump right in. Alex, give us a little bit of background as to what was the problem you're trying to address with these 2 different cluster randomized trials that we published.
As you know, I think better than most, Dr. Navar, statins are really effective and they reduce cardiovascular events in people at high risk for cardiovascular events, but too many people that should be on statins don't take them. And so what we were really trying to do is find better ways to help health systems increase the proportion of patients that should be on statins that are actually taking statins. And we specifically wanted to see if we could involve pharmacists in the process for a couple of reasons. One is that, the guidelines recommend a team-based approach to cardiovascular care, and, the pharmacists are such an important member of the cardiovascular team. And the second reason is just that pharmacists are, I think, so effective anecdotally in my practice at helping get patients onto the right medicines and sort of keeping us in the right bounds of appropriate care that it seemed natural to try and get them involved.
So we have 2 different trials, actually, that we were able to package into the same manuscript here. You tried 2 different approaches to get more pharmacist engagement for lipid management. Walk us through the first trial and tell us what you did and what happened.
So the first trial, we looked at best practice advisories or electronic health record alerts that would pop up when patients that should be on statins or should be on high dose statins but weren't were seen in an eligible clinic. And there was a pop-up alert that informed the primary care provider seeing the patient should be on a statin, giving them really 2 options. One option was a one-click option where if they just clicked OK, it would generate a referral to a pharmacist who would call the patient and get them started on a statin, or at least discuss getting them started on a statin. The second option that the pop-up had was really a 2 or 3-click option where they could start the patient on a statin themselves. And so this was a cluster randomized trial, randomized at the level of the primary care provider. And what we found, sort of to jump to the punchline, is that this strategy increased statin prescribing by about 3 percentage points above the usual care control. So there was an effect. It was actually not statistically significant, but sort of thinking about this in the context of some other trials and other studies that our group has done in the same space, a 3 to 5 percentage point increase in statin prescribing is about what we expect for this sort of EHR alert strategy.
Okay, so we got from maybe about a 3% improvement overall in statin prescription, but clearly not closing the gap in terms of utilization of guideline-based therapy. So then you tried something else. Tell us about the second trial design.
So in this trial, we took what we thought was more of a population health management approach. And essentially what we did here is we generated a list of patients that were seen in these clinics, that were assigned to primary care providers in these clinics, and they were involved in the study. And we generated a list of patients that should be on a statin and weren't. And then we essentially gave that list to the pharmacists, and we told them to call the patients. As sort of an intermediate step, we actually put in an order in primary care providers' inboxes that when they signed sort of generated this relationship with the pharmacist could prescribe in the primary care provider's name. But this trial, that's how we did this trial. So it was really just sort of bypassing the visit altogether and doing it outside of the confines of the visit. And we randomized 5 clinics to usual care and 5 clinics to having pharmacists call their patients. And what we found is that at the clinics where we had pharmacists call the patients, we entered the pendant order and had the pharmacists call the patients, we increased statin prescribing by 16 percentage points. So a much larger effect size than in the other study.
Yeah, pretty impressive. And, I'm curious, the doctors had the option to refer to the pharmacist in the first trial with a single click. How often did that happen?
They never did it. a single click would have referred them to a pharmacist, and they just never chose to do it. And what's interesting about that is that there are some situations where we as physicians recognize that pharmacists are sort of part of the care team. And the obvious example is Coumadin clinic. We almost never manage anyone's INR or manage their Coumadin dose. And it's just, statin prescribing, lipid management is sort of not one of those areas. So I think when it's presented in the course of a visit, when you have the patient sitting in front of you and it says, would you like to refer this patient to get a statin started? That's just it sort of doesn't even rise to the level, I think, in many physicians' eyes of like, hey, I should do this. This is something that will help the patient. Instead, they're sitting in front of me. I'll either start a statin or I'll just, click to get rid of this because they have other problems that I'm trying to deal with during the visit.
I was surprised to see that in contrast, over 70% of the automated orders that you put in for docs to co-sign were co-signed to initiate the pharmacist referral when it wasn't put into the best practice order, when it was just co-signing that order. What do you think was different about the docs being willing to co-sign the order versus having to click on it?
So there are a couple of things. I think that we are, it gets to the way that we think about things that show up in our inbox versus the way we think about EHR alerts. And in EHR alert, we're conditioned to get rid of it as soon as we can. We don't want to deal with it. It's just an annoyance. And we get rid of it by clicking the X at the top and it goes away. By contrast, a order for co-signature, we co-sign orders all the time. At least in our practice, our nurse puts in orders, a nurse practitioner puts in orders, and you have to co-sign it, and it's just there. So I think that the, maybe cynical explanation is that we're used to co-signing orders. We're used to treating orders for co-signing one way. We're used to treating EHR alerts in another way. I think the other way to think about it, though, is that, you have more time when you're looking at a pending order for co-signature. You have time to think about it. You have time to recognize what's going on and actually process it at sort of the beginning of the day, maybe when the orders go in. And I think that that's, one benefit of that sort of approach. And then the other thing is that we tried to actually batch the orders. So the primary care doctor got however many patients they had that were eligible. Those orders all came in at the same time, and they sort of could process it all together and say, hey, there's a program here that's trying to get my patients on an appropriate dose statin. They're involving a pharmacist. This seems like something that'll work, and actually trying to think through that. Whereas in sort of the EHR alert method, there's so many other things going on that they just don't have time to engage with the content.
So what's next then? This was a pretty impressive improvement in statin utilization. You did it in a large number of practices. Are there plans to scale this or grow it any further at your institution?
Yeah, so I presented this at the AHA Scientific Sessions in 2023, I think. And the press release got seen by the CEO of our health system. He was like, well, why aren't we doing this? And, so we talked about it, and, it turns out that we're doing it. So we're scaling this up across the health system right now, as we speak. And I think it speaks to sort of the simplicity of it. It's scalable, it's easy, it's resources that most practices have. And then also sort of I think there's something to be said about the economics of doing it, where our system at least is involved in a number of sort of value-based purchasing agreements, and getting patients on statins can be a net positive for hospitals' margins as well. And I think that that's potentially one way that this could get scaled.
And did you get any qualitative feedback? Perhaps most specifically, did anybody complain? Patients or doctors, why are you stealing my patients, sending them to somebody else, or patients complaining, why am I getting referred to somebody else instead of my regular doctor?
So we didn't hear any feedback from the patients. And I think that patients, for the most part, were really happy to hear from a pharmacist who called them at home. And, is sort of a well-trained clinician and practitioner that knows a lot about helping. And I think that most patients were appreciative of sort of the efforts that the health system was going to help get them on the right treatment. And then I think that, and part of that is also just the pharmacists that we had. We were lucky to have some really great pharmacists that were caring and empathetic and help walk patients through the situation. And I think, obviously it's not unique to the pharmacists we have in the study. It's a characteristic of many healthcare providers. There was some pushback from the doctors. 30% of them didn't sign the order. And what we heard from some of them were, I want to take care of my own patients. These are my patients, and I don't want to jeopardize my relationship with them by having somebody call them and talk to them about statins that doesn't know them and doesn't know the history, and we've talked about it and things like that. And, it sort of speaks to something I think that you've studied yourself, Anne-Marie, which is sort of statin hesitation in the community and statin misinformation and everything else. And I think that some physicians were, I think, reflecting that, or reflecting at least the fear that their patients would react in a certain way. But I also think that I said we were doing the study. Part of the reason to do studies like this is to show that things like this work. And so the next time we do this, we can say to physicians, hey, listen, we recognize that these are your patients and you're taking care of them and you're doing a great job, but you have a ton on your plate. Let us take something off your plate. When we do this, it works. And the patients get on statins and they're happy with us and it works out okay. So part of the reason to do a study like this is just to convince people and to convince physicians that this is a good idea.
Yeah, a number that stuck out to me is you had 437 patients that ended up getting a one-on-one visit with their pharmacist. And almost half of them, 198, started on an appropriate dose statin. And that really reflects some of the prior data that we've seen where a lot of people are not on a statin, say they've never been offered one, or perhaps they were offered one, but they forgot it. And I think it's nice to see data that those not on a statin include a lot of people who are willing to take one if we just can reach them with the right clinician at the right time in a way that makes it easy. Let me ask you a question for the future. People might be out there hearing this and saying, like, we have a pharmacist, they're underutilized. Let me do this at my health system. Looking back, having done this for 1,000 patients, what would you have done differently? Or what might you tweak to make it more effective or make it easier for you to implement?
I think the big challenge that we faced actually is just people answering the phone. And I'm not sure how to fix that. We called 566 patients. Of those, 129 couldn't be reached. We called 3 times. I'm not sure what the answer is. People get so many junk phone calls and junk emails and junk text messages. And I think it's increasingly hard, to cut through sort of the noise there. One thing that we didn't do in the study that might have helped is, and we've done in other studies, is we send people sort of a priming text message where we say, we're about to call you. This is Penn Medicine. Answer the phone when we call. We have something important to talk about. So I think that's one thing that we could have done differently. But I think that this is always going to be a moving target. For a while, people responded to email, and then email inboxes started getting filled up with junk. And for a while, and then people started responding to text messages, and now that's sort of going by the wayside. No one ever answered the phone when you called because no one wants to answer the phone. But I think that's the big question is just, how do you reach people? How do you get people at a time that works for them and they're ready to talk? And I think that's a challenge going forward. And I think it's continuing to be a challenge. But I think that's one of the hardest things here. It's just how do you reach people?
I think that's an issue on the clinical side, on the research side. And as we get more and more channels of communication, it almost makes it harder to reach people because there's so much noise. And then you did this in primary care focused on statins, but have you thought about expanding to, more complex secondary prevention or, other disease states like diabetes where we know there's underutilization of other guideline-based therapies as well?
I think this is a platform, the idea of sort of making a list of the patients that should be on a therapy and aren't, and setting up referrals to somebody who can get them on the right treatment is a platform that you can apply so broadly across such a number of conditions. Like you said, we focused on statins here. We focused on class 1 level of evidence A recommendations because we wanted this to be as broadly acceptable as possible. But there are obviously a lot of class 1 level evidence A recommendations across cardiology that you could imagine applying this to. I mean, I'm an interventional cardiologist in my day job, and I take care of people with complex coronary disease and peripheral vascular disease. And the number of people that I see that may be on statins but don't have their LDL less than 70 or less than 55 and need PCSK9 inhibitor or ezetimibe or something like that is not low. And I think that can we get those people referred maybe to a pharmacist, maybe to a clinical lipidologist to take care of them? I think that these are the sort of the other places that you could apply this sort of platform to. And it doesn't necessarily have to be a pharmacist either. And I think that the question is, how do you right size the expense and the intensiveness of the intervention? How do you right size that to the risk of the patient? And, the highest risk patients maybe should get the highest touch intervention, and the patients that maybe have a 10-year risk of cardiovascular events of 7.5% and have an indication for a statin should get a lower touch intervention. And I think that I see this as a platform that is scalable, and sort of adaptable to clinical situations.
So speaking of scale, you do have to have the pharmacist who's taking their time to meet with the patients. Do you have an estimate of, how many patients can one pharmacist handle? If you've got a health system with thousands of patients, do we not need an army of pharmacists to do this?
So when we're scaling this at Penn, we're estimating that one pharmacist can take care of about 3,000 patients per year. And that's sort of, back of the envelope calculations based on the pharmacists in the study saying, how long did it take to do this? So it is a lot of pharmacists for a large health system. I think one thing you can think about, though, is does it have to be a pharmacist? Because you think about other ways to do this. One thing that we're testing in another study is using patient navigators. So recent college graduates calling patients, sort of working down a more algorithmic way of taking care of patients, supported by and supervised by physicians or PAs or NPs or pharmacists. And I think that that's another way to potentially expand the reach because, in this study, we did have pharmacists making phone calls to patients and not getting answers. And so there is some inefficiency there. So we'll see if you can sort of replicate some of the benefits of a pharmacist program with maybe less expensive and less well-trained personnel.
Well, it's really exciting to see clinical trials now of actual strategies to improve the therapies that we know have worked for many decades. And congratulations to you and your entire team at the University of Pennsylvania for doing the hard work to figure out what works. And, as it relates to the best practice alerts, what doesn't work in terms of moving the needle on population health.
Thanks. Yeah. I mean, these are fun trials to do. They're important. And like you said, it's not necessarily a new drug or a new device or anything like that. Just trying to figure out the best ways to do the things that we already know how to do. I called it, it's just like blocking and tackling. It's the very basic stuff that we should be doing for all of our patients.
Well, I think this is a good reminder that many of the most effective interventions in population health are actually those that cut the doctor out of the equation and involve the care team. Not saying the doctor is not important, but there's so much on the plate right now of the primary care doctors that we really need their advanced thinking skills and diagnostic skills for, that the more that we can outsource some of the more algorithmic stuff, I think that would improve care for all. It gives them more time to focus on where there's a lot more gray area by having somebody else deal with the more black and white and the lipid space.
Yeah, and I mean, not to mention, if you implement this correctly, you can also really increase provider satisfaction and clinician satisfaction. I mean, I don't think that most PCPs want to be checking boxes all day. I think that the study obviously showing that it would take an average primary care provider 28 hours to sort of clear their inbox and do all the preventive stuff for their patients they have to do. That contributes to burnout. And I think that taking things off of primary care providers' plates is so necessary so that they can keep taking care of patients and keep doing all the things that they like to do. And I think that, one thing, and we actually talked about this when we were implementing this at Penn, is that you can't say we're going to take this off primary care providers' plates so that they can increase their patient panel by another 50. You have to say we're going to take it off their plates so that they can take good care of the patients that they already have and do the things that they like to do and do the things that only they can do and have other people doing the things that maybe somebody else can do.
I think that's a great point. Well, Alex, thanks so much for joining us today on the podcast and for sharing your research with us in JAMA Cardiology. Again, I'm Anne-Marie Navar. I've been speaking with Dr. Alex Fanaroff about his manuscript in JAMA Cardiology, Encouraging Pharmacist Referrals for Evidence-Based Statin Initiation, 2 Pragmatic Cluster Randomized Clinical Trials. You can find a link to the articles in the episode description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.